Good morning, everybody. All right. I have the pleasure of introducing our speaker this morning, Dr. Josh Liao. Dr. Liao completed his undergraduate at Rice, his medical school at Baylor, and his internal medicine residency at Brigham and Women's Hospital, where he was also a clinical fellow in medicine at Harvard Medical School. He completed a fellowship in health services and policy research at the University of Pennsylvania, where he obtained a master's, and he remains an adjunct senior fellow at the Leonard Davis Institute of Health Economics. Since his arrival to the University of Washington, Dr. Liao has assumed several prominent academic responsibilities that highlight his unique expertise. He served as the medical director for... Am I cutting out? He serves as the medical director for the payment strategy at UW-Medicine, and he is also the director for the Value and Systems Science Lab, the VSSL, that you can see here in the corner of the screen. His research focuses on evaluating and testing value-based payment and delivery reforms on patients, physicians, and healthcare systems. He has over 100 publications in peer-reviewed journals and over 70 publications in other outlets. So please join me in welcoming Dr. Liao to the podium to discuss his very interesting work.
Can you guys hear me? Okay, I think so. Well, good morning, everyone. I'm glad to be here, particularly as our nation and our national healthcare system continue to be in search of value, so to speak, and to think about what are these value-based payment reforms and how do they impact organizations and patients. Before I begin, I just want to note that the things that I share are mine and not those of my employers. Okay, can you guys hear me on the mic? Can you hear me now? Better? Better. Okay, I'm just going to keep talking here. I think I can hear myself in and out. So I want to spend the time with you guys this morning as we may swap out the mic here. 5 main things. The first thing I want to do is define value in healthcare. I recognize that some in the room may be more or less familiar with the term value or value-based payment. There's also an old saying. I spent about a decade of my life in the Houston area near the space program. Turn that off. Okay. You guys hear me on this? Okay. All right, let me start again. So there are 5 things I'd love to spend our time together doing today. The first is the divine value in healthcare because I recognize variation and expertise and focus on this topic. It's also an old saying in Houston near the space program that when you're launching a shuttle to the moon, that if you're off by a foot on landing, it's no big deal. You're still on the moon. But if you're off by a foot on launch, you end up millions and millions of miles away from your target. So I want to make sure we have a shared understanding of what value is in the room before we continue. I also want to define value-based payment reforms, both as a concept, but also contextualize it across the broader spectrum of how do we pay for healthcare in this country. You know, there are many reforms, plural, so what I'd like to do is leave you with 3 prominent ones. If you walk out of the room and say, you know, there are a lot of these, but here are the 3 main ones I should keep in my mind going forward. I'd like to move quickly into kind of what is the evidence about, do these things work, and if so, how and where? And then leave us a little forward-looking, thinking about if we were to look in 2019 ahead, what are some of these emerging issues related to the prominent reforms that we might want to think about as people in a healthcare delivery organization? So just to lead off here, what is value in healthcare? So what you're looking at here is what people have termed the value equation. I'm telling by a few nods here that some of you have seen it before. Broadly speaking, it defines value as quality over costs. Now, as everyone in this room knows, value is multifaceted because quality is multifaceted. And so we can think about quality in many different ways. One way is to think about it as structure. Structural quality can be thought as the literal physical infrastructure that promotes quality. So to use an example, for example, from cardiovascular care, that might be having a physical cath lab in your facility. It might be having AEDs readily accessible around the facility, things that promote that quality. As everyone knows, we are measured on process quality in many facets of our work. And so extending that example, it might be things like prescribing medications for a certain condition, doing diagnostic testing and the like, the process of delivering care and how high quality that is. We can certainly think about quality as outcomes. I won't say any more about that, as well as patient experience and satisfaction. Now, what about the denominator, so to speak? What about the cost? You would think that, you know, dollars are dollars and money is money, and so cost should be much more straightforward. And unfortunately, that's not the case. And those of us who spend our time working on it realize you can define costs a few different ways. The first might be charges. That, said simply, is the bill and what's on the bill. So provider organizations, say a clinic, physician group, or a hospital would bill to a purchaser. A purchaser could be an insurance company, directly to an employer, sometimes to the patient, him or herself. Those are the charges. If that's what is billed, what is actually paid out on the other side is what we sometimes term allowed amounts. Because the preponderance of payments are made via insurance claims, we really think about it as claims spending. And then one other way to think about costs could be via allocation. And by that, I mean, when we think about clinical units, service lines as a hospital, what we're saying is that we have to allocate costs somehow. A department, a service line, a clinical unit, patient registration, janitorial services, the cafeteria, all of these hold costs. And sometimes when people talk about costs, they mean it in that way. So there's a variation as well. Now, what's kind of baked into all of this is this notion of value is that, as I mentioned earlier, if quality and cost are multifaceted, it's not surprising that so is value as a concept that's based on those two principles. But the other thing that's here is a matter of perspective. And as Jeff mentioned, I'm fortunate to be a senior fellow at the Leonard Davis Institute. And this is an article that I wrote a few years ago thinking about when we say value, who are we talking about? Said a different way, value to whom? And I just want to highlight here that there are intrinsic and inherent trade-offs to these perspectives. And we won't spend our time doing this together this morning, but I'm sure if we put our heads together, we could come up with at least a few clinical situations where a certain test, a certain treatment, antibiotics, advanced imaging, opioids, et cetera, the value of that decision, that thing, could vary by patient, patient caregiver, clinician, healthcare system, and society writ large. And I don't necessarily think there's a right or wrong here. It inherently is, but I think recognizing that allows us to move in progress and the discourse forward about what we mean in value. So I just wanted to highlight that value without a stakeholder perspective to me is a bit handicapped in that way. So if that's a value in healthcare, broadly speaking, quality over cost, how do we think about value-based payment reform? So here what you're looking at is a spectrum of healthcare payments. This is not value-based per se. This is just a sampling of different ways we can pay for healthcare in the country. Don't worry, we're not going to drive through these details. I put this here to make the qualitative point that there are many different options, and they're not mutually exclusive. They can come in combination and be sequenced together. You can take this, though, and organize it in a different way. You can put it along a spectrum, as I've done here. So this list is the same one you just saw, but it's organized along a spectrum going left to right here. And one might say on the left side, this is very volume-heavy or volume-based strategies. And on the right side, you could say they were more value-based strategies. And if we kind of bring forward that notion of value being quality over cost, what does this really mean? It means that we can think about this as a gradient. In my mind, I think about it as a gradient of quality improvement incentives. Now, certainly people on the fee-for-service side, I don't mean to say that they want to give low-quality care. That's not the point. The point is that there's nothing hard-coded into that payment strategy that incentivizes that behavior. And contrast that with something like pay-for-performance, which by the name perhaps gives you the intuition that the payment itself is tied to the quality of performance of that care. None of these are perfect, but there is an increasing dose response, so to speak, as you move from the left to the right of quality improvement incentives. What about cost? A similar point can be made. I don't think anyone sets out to be wasteful on the fee-for-service side. The point is simply that if there's a criticism of that system, it's that there's no inherent incentive there. Contrast that with something on the right, capitation in its few flavors. For those of you who are less familiar, capitation by the name, as it suggests, is a payment per capita. So it's to say that a fixed payment is made per person cared for. And so in that way, anything that a provider organization spends on a patient above and beyond that is absorbed as loss. So you can imagine the pluses and minuses there, but suffice to say there are very strong cost containment incentives in a capitation arrangement. So as we move from here to here, when we say volume to value, what we're really talking about, in my mind, is an increase in quality and cost-driven incentives that are hard-coded into the payment reform itself. So others have done this. I'm not the only one to describe this, of course, and they've taken this spectrum that you just saw. And I apologize, my slides are going out of order here. They take this spectrum you just saw, and they've essentially given it a little more structure. So they've color-coded it, they put it in categories, they've given you boxes for subdivisions to describe the nuance. But in general, this orange, as you can see here, fee-for-service. And way over here in category 4, the green is things, you'll see things like capitation and the like. And so the same spectrum holds. And for the purposes of our time today, when I say value-based payment reform, I'm talking about drawing a bright line down the middle here and talking about everything on the right. Okay? So put that into words. One can define these payment reforms as programs that increase value by holding providers financially accountable for the quality and cost of care. And again, at the same time, think back to that quotient. These are reforms, so to speak, because they're attempting to reform widespread volume-based fee-for-service incentives. Now, there are a few of you in the room who may know that, in different markets, there may be more or less fee-for-service, but the overall prevalent driver of fee-for-service, that's what we're trying to, quote, reform here. Now, if it's important for us to understand what these reforms are, I think it's also important for us to understand what they are not. So before we move on, I want to highlight a few close cousins that are a bit outside of what I'm talking about today. So quality-based programs, Department of Medicine here in the general medicine world, things like patient-centered medical homes are critical. We'll touch on those a little bit later, but they inherently are not payment programs, right? They're meant to improve quality and coordination and continuity, but they don't carry that focus on the denominator of cost, and so I would not consider that a value-based reform. What about value-based reforms with an incentive? And so perhaps the most notable example here is the readmissions reduction program. As many of you may know, we are penalized, as all hospitals are around the country, for excessive readmissions. Why do I distinguish that? Whatever you think about readmissions as a quality measure, it's ostensibly designed to measure quality, and there is an incentive. There's a penalty if you have excessive admissions, but it does not compel us as providers to focus on the cost, for example, of those readmissions. There's not a simultaneous balancing of quality and costs. So I would put that to the side as well. What I mean here by service or customer engaged programs are things that focus on patient satisfaction, patient experience, critical to the work we do, but adjacent and outside of kind of what we'll talk about today. And then finally, if the focus on quality without cost puts someone out of the bounds here, then so does the opposite, right? So there are a number of cost containment initiatives that I would not consider value-based because of an underemphasis on quality. So keeping that quality equation in mind, how could we increase value? And there's really three forms. I didn't make these up. These are actually written into federal statute as well as a number of plan policies, but there are three ways to do it. You can increase the numerator, increase quality, and hold costs the same. You can do the opposite. Keep quality stable and reduce costs. Or maybe more ideally, you could do both, increase quality and reduce costs. These are the three forms. And every model we talk about today really is predicated on one of these three. You can ask the question, what is the intended effect of these? And it's one of these three in terms of increasing value. So where are we? We talked about this, and certainly value and value-based care and payment have made its way into kind of the healthcare community, but exactly where are we with payments and how much value is there? So in the same group that I showed you the color-coded framework, they put together an annual report. So their 2019 report, which is a year lagged because of how data lags go, show that in 2018, around the country, all in, 40% of all healthcare payments around the country are still fee-for-service. So fee-for-service is not 90%, but it's also not 10. 25% live in that kind of middle intermediate category, that red category, if you will, and I'll show you a picture of that to kind of solidify it. And upwards of a third of all healthcare payments around the country, hospitals, clinicians, et cetera, come in the form of what I'm calling value-based payment reform. Let's drill down for a second. Of those models, the more intense ones that say, hey, you are on the hook financially for the cost of care, about 15% of all payments are tied in some way to that. And if you want to ask, well, who? Which stakeholder, who's driving this trend? It really is Medicare in its two flavors, Medicare Advantage as well as Medicare fee-for-service. This is showing the same information kind of in a pictorial way. And what you're seeing here again is 40% of all payments in fee-for-service, 25% in the intermediate, and north of a third kind of in more value-based payment reforms. So if you trend these over time, it's incremental. I don't want to oversell it, but the proportion is increasing over time, and the arrow is clearly going up in terms of the proportion tied to those. So we've covered a lot of ground already, particularly for those of you who don't spend every day thinking about this, but what have we talked about? We've talked about value defined as kind of the underlying concepts of quality and costs. We've understood these reforms as moving from volume-based to value-based, aka quality and cost-based incentives. And we've kind of contextualized that within the broader spectrum of how we can pay for healthcare. And made the point that a notable and I would say increasing proportion of payments are being tied to these value-based payment reforms. So with that said, what are these prominent types? So there are, on my last count, I keep a running log here. There's probably, in my mind, something like 30, 35 of these, at least even in the current version, if not more. But I want to leave you with three ideas. Okay, so going back to this framework, that's a good starting point. If we, again, make that bright line in the middle, we focus on things only on the right, and we zoom in on that right side. Once you take that text and you ask, well, what clusters together and what are just variants of each other, I think there are three models that come to the surface. The first are accountable care organizations, or ACOs. The second are bundle payments or episode-based programs. And the third are primary care models. And these are the three that we'll spend the rest of our time talking about. So what are these models? And it's at this point, actually, that some of you may have experience in them, and I would welcome people raising their hands and questioning or clarifying these, because I think this is the launching point for the rest of what we'll talk about. So the goal of ACOs is really to hold providers accountable, again, for quality and costs. And the key operative part here is for a population of patients. So every ACO, which is a collection of clinics and hospitals and post-acute care providers, et cetera, get together, and then there's a population that is defined for that group. The performance period is generally 1 year. So in terms of how am I performing, you have a year to do that. And quality is defined, and many of you may be familiar with ambulatory process-based measures, things like immunization, screening, preventive care, et cetera. Costs are all in. So costs are from a paid claims, in this case, Medicare or an insurance company perspective, all in for that population. You have 20,000 people in your ACO, you take all the claims for those 20,000 people, you add it up, that's your cost performance. There are ways to take out outliers, et cetera, but that's the general concept. Key examples of that would be the Medicare Shared Savings Program, or MSSP. Something that might be closer to home is that we here at UW have a few large ACO-type contracts with employers, including Boeing. So if the focus of ACOs is really on quality and cost around a population, Episodes takes that and turns it and asks the question, what are the quality and cost accountability incentives around episodes of care? And in that way, performance periods are defined by the episodes. Now here to date, episodes have been defined by hospitalization and post-acute care. So I get care under this bundle payment, and when I'm admitted to the hospital, the timer starts. I go all the way through my hospitalization, and then when I'm discharged, another 90 days. That's the episode. There's nothing inherently magical about that. And in fact, people have begun to design different types of episodes, but that's what exists to date. Quality in that way is then very episode specific. So for example, for a surgical procedure, you might have surgical complications as an episode specific quality measure, as well as general ones like readmissions. Costs, again, are episode based in the same way. And examples, there's large Medicare programs, which we'll touch on in a little bit. And I'll just highlight this Medicare maternity bundle as one that's designed totally different. You know, maternity is not something that Medicare focuses on, but Medicaid has designed bundles that are defined from a prenatal visit at 6 or 7 weeks going all the way through delivery of the newborn. And so you can really move and redesign episodes. Primary care models, I'll just touch on this quickly. The goal here is the same notion, quality and cost accountability. I'm beginning to sound like a broken record here, but is really around a defined primary care population. So why is that in distinction to ACOs? The notion of ACOs is that any care in any form could be included in that ACO, but that care could be subspecialty care, it could be transplant, things that are not in primary care. So if there's a wrinkle here, it's that the primary care population is based on people who receive primary care from participants in these programs. The other parts are pretty similar. 1 year period. Quality measures are very similar, ambulatory process based on process and outcome. Cost is defined either as total all-in claims, what I just described for ACOs, or as primary care costs, where they kind of subgroup out just the primary care spending. And then there are examples, and the one we'll touch on today is CPC, comprehensive primary care. Now, what I didn't put on these slides is that each of these have an incentive component to it, this notion that behavior follows incentives. And so what I'm not putting on here, because it's a bit technical, is that if you're able to contain costs or improve quality, there are certain financial payouts for that are baked into all of these. Before we leave this section, I just want to highlight that, this is, again, that value equation I showed you. I kind of fanned out over the different ways to think about quality and costs. I want to just really level set about, well, when we think about these programs, what are they really doing? Which ones are they focusing on? So they don't focus on structural quality. They don't really focus on charges, and they don't focus on cost via allocation. And the reasons for, I don't mean to say that there is no corner of the country where we can't have more structural quality, but overall, we've moved a bit beyond that to things like process and predominantly outcomes-based performance. And so structure is really not encoded in these models. Charges, they definitely exist, as we all know here, but I think there's a recognition that we need to move beyond them. And frankly, very little of care is paid for on a charge. When a provider bills a charge, very little of it just gets paid on that charge. It's negotiated and paid in this allowed amount. So that's really not focused on here. And cost and allocation, imagine today we are in DC and we're trying to run a big Medicare program. And if you were to ask costs for 1,000 or 2,000 hospitals around the country, how would you do that, right? It's very hard. Each accounting system's a little bit different. They allocate costs a little bit differently. It's really infeasible. So what we were talking about in the value equation for those three models, ACOs, bundle payments, and primary care, really are process and outcome measures. And I put this in a kind of a yellow-orange because there is some measure of experience, but I would say it's weaker compared to the other two. And then on the denominator side, we're talking really about claims paid. What is actually paid for the care from an insurer or a purchaser? So quickly summarizing again, I think we've talked about prominent payment models as these three. They differ in terms of scope, quality, cost, some of the specifics, but they all seek to drive that value equation. And they primarily all do this via quality and process and outcome with some experience, and cost, so to speak, through claims spending. So what's the evidence? I want to drive through this relatively quickly here. What's the evidence for these three reforms? Now, a word on methods here. The purpose, of course, is not to do a deep dive in the methods, but what I really love about being in a place like this university is that each different field, translational research, basic science, in my case, policy and economics, we all use different methods. And I think getting the kind of core concept of it now helps you understand what we're talking about, but it also helps you understand, okay, the model that's going to show up next year is probably going to be in this method. So I just want to give you a word on it, and we'll keep moving. So the core problem here is, while I would love to test these payment reforms in a randomized controlled trial experiment form, we can't do that. It's just simply not how that works. I can count the exceptions on one hand. And so what that compels us to do is look for methods that help us recreate those experimental conditions. And econometrics is a field of study that allows us to do this. I say us in a very direct way. This is what I focus on in my research and colleagues and I work on. It's a set of economic tools that help us say, how do we get as close as possible to experimental, recognizing we're looking back in time after a program has already been implemented. If I was to pick out the one method that's relevant to our talk today, it's this thing called difference in differences. Just actually for my edification, how many of you are familiar with difference in differences? Okay, great. So less than half of the room. And so hopefully this is helpful. This is a little messy, but hopefully I can give you the intuition through this slide. So it's a retrospective method, so similar to observational cohort studies. What you're doing is you're looking back and you're identifying an intervention group and a control group. And that's denoted here by the red and the green lines. The difference may be that it's a time panel method, meaning you're trending things over time and you add a wrinkle to get at what is the impact of the policy. So let me orient you. On the x-axis here, you have time. And this vertical bar is the intervention, the policy, the ACO going live, the primary care model being implemented, wherever you'd like. So everything before is pre and everything after is post. This is an outcome, call it spending, call it a quality measure. And the notion is that you see there's a difference in this figure, right? That the intervention and the control groups, they differ. But the key is that it's a constant difference. There is no difference in the difference. If there is one, it stays steady throughout the pre-period. And so the idea is, in the absence of any intervention, you would expect these lines just in perpetuity to keep going in parallel, right? So in this method, what you're looking for is at the time of the policy, you're expecting the unaffected group, the green line, just to keep going, and the affected group, the people who are in the payment model, to take some inflection, up, down, or otherwise. And so what you're measuring in this difference in difference approach is really this right here. If I can keep my hand from shaking, it's that delta. The intervention effect is the difference in the difference after the program goes live. And I spend this time doing this because everything you've ever heard, ACOs work, CPC works, patient medical homes save money, they're all predicated on this method with some bells and whistles, of course. Okay? So with that said, what do we know? Kind of quick capsule summary here. With ACOs, I'm going to highlight the Medicare Shared Savings Program, in part because it's the largest one. In part, Medicare is the leading, when I showed you that, where's the value-based payment, Medicare is the leading payer in that. And Medicare's flagship ACO program is MSSP. Growth has increased over time, and the policy is moving more and more down the spectrum to value-based, meaning it's saying you need to take financial risk and you need to do certain things, okay? So I think it's a good example. And this is a study that was published by colleagues in Boston who looked at 3 years of the MSSP program using a difference in difference method. And what they showed, essentially, here's the top line. They separated ACOs into physician group ACOs, aka ACOs that do not have a hospital in the network, and hospital ACOs. ACOs that could have anybody, any group, any network, any clinic, but has at least one hospital. And they looked at those separately based on the differences that could be there. And what they find is that physician group ACOs reduce spending, and that spending reduction increases over time. It squares with the notion that the longer you're in a program, the more investiture you make, the more time you have doing things differently, the more benefits you can gain. Hospital integrated ACOs had reductions, but they were much smaller, and they extinguished much more quickly. As I mentioned earlier, all of these programs have that kind of payback. Like if you reduce spending or improve quality, you get a little bit of financial incentive. So from the Medicare perspective, once you account for these, quote, shared savings, once you pay back that money to the provider organizations, it actually nets out the hospital integrated effect. So from a Medicare perspective, from a societal perspective perhaps, the hospital integrated ACOs don't actually save money, but the physician group ones do. A word on utilization and quality. What they found is outside of things like ED visits, the other things like hospitalization for ambulatory sensitive conditions, readmissions and the like did not change between the groups. So I think taking a big step back and thinking back to how do we get at greater value, this really is a quality stable to maybe slightly improved, but really driving costs down if ACOs work. One more word on magnitude is that we're talking about hundreds of dollars, maybe $1,000 or $2. This is not millions of per patient. This is not like $10,000 per patient. So in the analog of MSSP is the flagship ACO program. What's the flagship bundle payment program? And that's BPCI. And BPCI is the largest program we've ever had actually in bundle payments around the country, and it wrapped up late last year. It defines the episodes the way I described, hospitalization through 90 days of post-acute care. And there were 48 episodes, meaning people could have gotten in for things like heart failure, MI, UTI, renal failure, CABG, bowel procedures. But far and away, the one that people signed up for was joint replacement. So that's really where the data are. So a few groups have studied this over time, including one that I co-lead, and a lot of the data really has been around early performance. What are the characteristics of these hospitals that get in? What are the early performance? And there's a paper that's actually currently in press, and fingers crossed is going to publish before the end of the calendar year. So I'm going to preview some of that data with you. This is a difference in difference study from a group that I co-lead. And so what you're looking at is a forest plot. And the reason you're seeing percentages on the x-axis is, again, you're looking at the incremental difference between intervention and control. And so the idea is that point estimates and bars that are to the right means that you have more of whatever you're looking at, more spending, more readmissions, more fill in the blank. And the things to the left of the 0% are relative comparative decreases in that outcome. So stepping through this quickly, what we see is that when we look at hospitals that are in these joint replacement bundles over 3 years, what we notice is that overall, you have, looking at spending, you have decreased spending, okay, of several percent. What we did was we kind of looked at that more carefully, and we said, what if you look at the early versus late period? So is it you get all the juice out of the squeeze, so to speak, early, or is it later? And what you see is it comes in the early period. So it's right after the program initiates that you get all the benefit. Well, who's driving that benefit? So a very similar but different question is, which hospitals, the early joiners, the Wave 1 hospitals, or the late joiners, the Wave 2 hospitals, are driving this effect? And it turns out that it's the early joiners, that the early joiners, whether early in the program or late, they're the ones getting a lot of the benefit in the spending reductions, and the Wave 2 hospitals aren't. There's something inherently different about them. What about quality? I won't show you this in the interest of time, but similar to the ACOs, we did not see, for the things we can measure through these data, we did not see differences in any of those quality or utilization measures. So really is a keep quality stable, but achieve cost savings approach to increasing value. This is a figure from a study that colleagues in Boston did, and what they looked at, if you look at the bottom here, instead of looking at joint replacements, they looked at these medical conditions, so MI, heart failure, COPD, things that are relevant for those of us in medicine. And the kind of top-line takeaway is that there were no differential changes in spending or quality outcomes. I won't go into the reasons for this, but I'll just say that there is reason to think that the way we've designed bundle payments, you see it in surgical episodes, but you don't see it in medical episodes. So primary care models, CPC program. So this program is a program that was region-based. It is concluded now. It was a 4-year program, and it wrapped in 2016. And it was a multi-payer program. So you might be wondering, well, those are very interesting regions. How were those picked? And what Medicare really wanted for this to be was a multi-payer program. So they went around and tried to find areas where the Blues, United, Aetna would get in and say, if you fragment incentives across payers, you really undercut the ability to drive change. So I'm going to pick regions where there are multi-payer agreements to do this together. And that's how these regions were picked. And it emphasized the 5 functions of comprehensive primary care. And here are the functions. And to be clear, these were not created by CPC. They were just operationalized by CPC. These things have been around for many decades. The first is risk stratified care management. This might be taking a kind of a hot spotting or otherwise approach to segment your population, looking for high cost or high utilizer patients, and then deploying care management interventions to them. The second is access and continuity. The third is planned care for chronic conditions and preventive care, really coordinating care for people with multiple chronic conditions. The fourth is engagement of patients and their caregivers. And the fifth is coordination of care across the medical neighborhood. Now, the medical neighborhood, for those who may be less familiar, is kind of an evolved concept that came from an earlier concept of medical home. Medical home being this idea of a patient centered around a foundation of primary care, getting the care that they need when they need it, and then the neighborhood being kind of the array of specialists and other people and services that are around that. That's the medical neighborhood. So similar, did it work? This is an evaluation from Medicare contractors of the CPC program. Difference in different study. And here's another figure to kind of test that intuition. It's a little bit lighter, I apologize, but here is that intervention where CPC began. And what you want to see if it quote works, or if there's a difference, is at that point, these lines should diverge between CPC and non-CPC practices. And your eyeball test is probably validated by the statistical models, which is that they do not diverge, and that outside of a small relative change in ED visits, everything else is pretty neutral. Now, a number of reasons have come up about why this might be, and I want to spend a few moments on it given the medicine focus of this model. One idea was that we need stronger incentives. The incentives are just too weak. You need to give a bigger dose of the policy. Some thought people didn't have enough time to change care. You can't just do this overnight, and so maybe that was part of it. Some people thought despite the multi-payer arrangement, you still have too much variation and too fragmented of incentives. There was another thought that the administrative burden was too much. So it takes a lot to report and to do feedback and to be compliant with these programs. And finally, this notion that did the incoming tide lift all the boats already? You have the hospital readmissions reduction, you have ACOs, you have bundled payments, you have hospital value-based purchasing, things that have been around for half to a full decade. Does it make it hard to see incremental change above and beyond that? So, I would say, these are all leading likely candidates. These are being fleshed out in other programs. There's currently one called CPC Plus that is ongoing as we speak and ends in 2021, and other programs in the pipeline. But to summarize quickly, I would say that overall, ACOs, and these lines take the data I showed you, as well as others that I didn't have time to show you, but overall, ACOs have led to overall positive results, albeit small. But they vary by the structure, whether you have a hospital or not in the ACO, and the time of participation. The longer you're in it, the more you can drive improvement. A similar thing for bundled payments. Overall positive results, small in the absolute sense, but it varies by episodes, so surgical versus medical. And it also varies by when you get in, an early joiner versus a late joiner. And then primary care models. And again, I want to highlight that there are many evaluations of programs that are quality-based with incentives. I'm not talking about those, but as operationalized within a value-based payment reform, it's been neutral to date, and I think more data and evidence is needed. So with the remainder of our time, I'd like to talk a little bit about emerging topics for these 3 reforms. So all these data I showed you were from 2012 to 2017. So we're sitting here in a provider organization in 2019. So what's ahead here? A quick word on emphasis. Do I think the emphasis is going to change? If I had to pick one question I get asked, whether I'm giving a talk at a conference, I'm on the phone with colleagues, people ask me this kind of in casual conversation, is this all going away? And in a word, I would say, no, I don't think so. And ACOs, which have been very heavily emphasized around the country, there are more programs in Medicare that are coming out. Again, more employers are picking it up. Private insurers are moving towards these products as well. While bundled payments, I also think that emphasis will continue. It's already been emphasized. I was actually on the way here talking with someone about how more and more episodes are going to different spaces. Yes, we're talking about joint replacement and COPD and sepsis, but now we're talking about things like general surgery. We're talking about things like cellulitis. We're talking about things like hospice care, renal failure. So I do think that will continue. Here's some programs that substantiate that. I think in contrast to the, quote, continued focus of these two, I do think primary care models, though, are getting an increasing emphasis. So some of you may know that earlier this year, Medicare pretty directly said, we want to invest more in primary care, and we want to do that on the backs of 5 new models. So the CPC Plus model is the one I was referring to earlier. That's currently live around the country and will end next year, and we all await those results. But the new models that are in the pipeline that will hit 2020 and after will be primary care first and direct contracting. They each have a few flavors. They're complicated. I'm happy to take questions about them. We won't do a deep dive, but I would say the number and the incentive of each of these programs suggests increasing emphasis on primary care. So with that either continued or increasing emphasis, what might be the key issues that we should think about together as a provider organization? I think for ACOs and bundle payments, as I see it, is 2 big things. The first is co-participation. So what happens when a hospital or a physician group gets into multiple programs at the same time? So I'm a hospital and I sign up for ACOs and I also sign up for bundles. Well, on one hand, that might be good. It's a common focus on value. You're another reason to focus on readmissions and other things. But as all of you in the room know, there are limits to how to engage clinicians and what people can do. And so do you get redundancies? Do you get conflicting initiatives? If you have a program that focuses on primary care and another one focuses on subspecialty care, how do you split the investment and those types of things? It's not clear that it's all positive. So if that's on the provider or the clinic or the hospital, what about the patient? So in this example, it would be Josh lives in the Seattle, Puget Sound area, and I get my primary care from a provider that's in an ACO, and I need my knee replaced by another provider that's in a bundle payment. So the models don't overlap in the provider, but they overlap in my care. Is that good or bad? We could articulate a very similar line of thinking. I think in contrast to that, for primary care models, given the what is to date more neutral evidence, I do think that among other things, more data, et cetera, I think there can be an opportunity for frameworks that help us distinguish what we mean by primary care interventions. And I'll unpack what I mean by that in a second. But let me touch on co-participation first. So this is a study for the nth time here, a difference in difference study that I led that was recently published, looking at co-participation. And what we did was we looked at co-participation in 2 programs we've already talked about today: joint bundles in the bundle payment program and Medicare ACOs. Difference in difference with a bit of a twist. And we looked at a number of outcomes. I won't drive through these individually, but trust me when I say they're the same ones that the other programs looked at. It's spending, utilization, quality. So back to the forest plots. Here's what we found. So when you look at hospitals that aren't in either of them, so they're not bundling care and they're not doing ACOs, compare them to the bundle payment participants, what you see is that actually a decrease in spending by 3 or 4%, as well as a relative decrease in readmissions. So this squares with the data I showed you earlier, the body of literature, and is overall a positive. We would do the same thing, but instead of looking at just those bundling, you look at no participation versus both. And you see that you also get comparative cost savings on the episode. Actually, it washes out. There's no difference in these primary quality measures. Here's where it gets interesting, at least to me, which is when you look at people who are single participants, only bundling joints, and you look at people who co-participate. So what happens here? My prior assumption, not to reveal my propensity as a Bayesian here, but my prior was that it would all hug the line. There would be no difference. But in fact, what you see is that compared to people who are only bundling joints, the co-participants have a relative increase in unplanned readmissions. It's a little perplexing and a little bit startling. Now, before I go on, let me say there's no study that's perfect, but in these studies, what we do is we take a whole array of things to account for confounding. So we look at things like, I'll give you a quick snapshot, things like patient age, sex, comorbidity, dual eligibility, where they live, area income, area education, area poverty. We look at hospital characteristics, size, teaching status, urban, rural. We look at market characteristics, how much MA is in the market, how many beds are in the market. Just to give you a flavor, we really try to sop up all of that confounding, try to get at this. And it's, again, not perfect, but this is not a simple correlation as well. So if you think about the readmissions, so then the question is, if we drive forward and say, well, what's happening in the post-acute period that might be driving it? This is what you're looking at now. So again, the same groups, you're comparing co-participants to the single participants. And what you see is that compared to those who only bundle, those who are doing both have a shorter length of stay in the hospital. They're having more outpatient follow-up within 7 days of discharge, and they're discharging home with home health less. One could summarize this and say that the post-acute utilization patterns differ for these 2 groups somehow. So how have we put this together? And what's the kind of, and this is the first evaluation of co-participation in the country, so I'm hopeful that more data will come from our group and others, but what can we conclude from this so far? The top line thing, I think, is that overall co-participation does something very similar to single participation. However, we did see a few things that differed with unplanned readmissions and post-acute care utilization patterns. And how might we square that? One leading theory that we have doing this work is that it's very well known that a bundle payment strategy is after you replace a joint, for example, you send someone home or home with home health if you can do it, right? If it's clinically appropriate, rather than just automatically sending them to skilled nursing facility, which drives up the spending, send them home. Shift the discharge location. If you parachute into any group talking about bundle payments and you said that, they'd say, that's right? That's a tried and true strategy. But the ACO strategy is a little bit different. When you talk to ACO medical directors and people who run those, what they'll say is we really try to clamp down on inpatient utilization. We really try to leverage our ambulatory and primary care infrastructure. And so one hypothesis, and it's that at this point, is that it may be that co-participants who sign on to those incentives in both are leveraging the ACO strategy, focusing on getting people out of the hospital, back into outpatient follow-up, and really not thinking so much about this skilled nursing facility versus home health issue, whereas people who are bundling are only doing that. And I think highlights that point I made earlier of the cultural and the operational drag that can occur. You're a clinician, should you do this, should you do that? Some overlap, some parts overlap, some don't. It can be complicated. So co-participation is one thing. I'm going to quickly mention overlap here, again, which is on the patient level. And this is a descriptive study that we published recently that asked a simple question. Of all the people who are in ACOs, how many also get their episodic inpatient care through bundle payments? Okay, just a simple count. And vice versa. Of all the people who get any episodic care, kidney failure, UTI, cellulitis, bowel procedures, joints, CABG, 48 of them, anybody who gets that hospital care, how many of them also happen to be in an ACO? And it turns out that it's, not the majority, but it's non-trivial. And so we see across the country over a 3-year period is that when you think about overlap from the perspective of people in bundle payments, it's north of 25%. And when you ask it the other way, and from the perspective of ACO participants, it's 1 out of 10. And this data is lagged, and this is not published, but there are reasons to believe that since 2016, this number has only increased. And I'll tell you anecdotally, when I work with partner organizations around the country, some of their specific, we're talking about millions of people here, when you ask the question on a couple hundred people for a hospital or hospital system, a couple thousand people, overlap can be as high as 80%. I think the highest I've heard is like 85%. But essentially you're co-managing all of their care. So how do you engage primary and other ambulatory care clinicians and orthopedists and cardiac surgeons? Again, that's a key issue here. Let me end by saying this, frameworks for primary care interventions. What I mean by this is that I think it's pretty incontrovertible that there's a large body of evidence saying that more primary care is associated with better outcomes. I'm not arguing that point. But I would say that in contrast to some of these other models, the data are varied. They're heterogeneous. And one of the reasons is in the variation of how we define primary care. If you take a big step back, some people will talk about primary care as kind of a national investiture. Right? So how much money do we put in primary care? How many clinicians do we have per area density? That's certainly one way to think about it. You can compare us to Germany or Japan or any country you'd like. Other people talk about it as a specialty, right? Are we talking about internal medicine, family medicine versus other specialties? Some people talk about it as a profession. So are we talking about physicians or non-physician clinicians? And some people talk about it like a basket of functions, like those 5 I just showed you, continuity, engagement, et cetera. And there are 5 that are basketed together. And I think some of this variation, what it leads is a little bit of noise. It creates a potential challenge in understanding, so what are the things that are going to help us drive forward? And I showed you a few reasons why CPC didn't work. We'll be evaluating CPC Plus soon. And I think some more framework and rigor around this can be very helpful to all of us in primary care and medicine and in the house of medicine, so to speak. So let me illustrate that with 2 quick points here. You're looking at the same slide I showed you earlier about the 5 functions of comprehensive primary care from CPC. I want to just make a comment about risk stratified care management. This is a paper that I was fortunate to write with colleagues actually in the Department of Medicine here at UW. And the motivation for this paper was really this idea that there is widespread enthusiasm around the country of using things like hotspotting, segmentation to identify your high utilizers, high spend, high risk patients and intervene on them. And I think the data overall is still out, let me be clear, and that there can be rationale for them. But one of the challenges with that is that the data we have in primary care, the idea of taking those patients and then delivering intense primary care services, has been pretty lackluster so far. One of the things it creates is a focus on those segments creates a kind of a narrow perspective that could be problematic if it prevents us from thinking about broader interventions that could affect more patients. So let me give you a quick illustration to hopefully drive home what I mean here. So say you have a distribution of patients by cost, and this is inappropriate cost, right? We're not in the business of just reducing costs to reduce it, but if we identify an area where there's inappropriate costs and we want to reduce that, a hotspotting or a kind of segmentation approach would be to say, let's identify that top proportion and let's focus our energy on delivering that in a risk-stratified, high-risk care management approach. Let me give you an example, a real example from a real analysis in Medicare patients. This was colleagues in Boston where they looked at was low-value care services, things that, again, one could argue are less appropriate to do in many settings. And what they found was that if they hotspot, you find that 17% of Medicare beneficiaries amass the highest risk of having low-value services delivered as part of their care. It's over 2 or 3 times the risk. And that the rest of the people are lower risk, average or low, and it's 83% of the population. When you go look at the spending, though, it turns out that only 27% of the spending, is concentrated in these people, whereas the rest is concentrated in the other section. Now, how do we explain this? 2 things I want to kind of put forward here. The first is that there are so many people in this wedge right here that even if you were to focus on, you leave this airspace, so to speak, uncovered. And sometimes segmented interventions, we've seen this locally in other health systems, will do that. The second thing is if you focus on this subsegment of the population, you have to get that much more effect out of each person. You have to reduce low-value care, in this case, that much more per person to get that same overall effect, whereas if you could come off of low-value care in a smaller effect with more people, you get the same overall benefit. So I just want to simulate this idea that is an issue of, I can't say that it's wrong, but a high-risk segmentation care management approach, there are questions to be kind of discussed about it. One more here, coordination of care across a medical neighborhood. So this is the ACP, American College of Physicians, definition of a medical home. And as I mentioned, a medical neighborhood is kind of the evolution of a home when you kind of build a community out, so to speak, to have a whole range of care for patients. And, there's a lot that's been published about PCMHs, patient-centered medical homes, and I'm not talking about those. I'm talking about the evidence that exists for PCMHs within value-based payment reforms. And this is a big study that was published in late 2018 that showed that if ACOs use PCMHs, it leads to higher quality, lower costs, and headlines abounded. I actually was very excited to see this report. When you drill down on where this comes from, this is now for the final time, a difference in difference analysis, looking at ACOs. And what they did, I want you to focus on this block right here. What they did was they took ACOs around the country and they said, let's look at those ACOs and take their PCPs and ask the question, how many of their PCPs are PCMH certified? I don't know how familiar you guys are with patient-centered medical homes, but there's 2 variants. One is a certification, where if you meet certain competencies, they check off and they say you're certified. And the second is actually redesigning the care, changing referral patterns, using the EHR, et cetera. This is based on certification. So they looked at certification and then they put it into 4 quartiles. They said, if you're an ACO with not that many PCMH certified PCPs, you're here in quartile 1. If you're the highest quartile, you're here, and so on. And really the top line thing that made all those headlines was this number here, which is that if you compare to the ACOs with the least PCMH certified PCPs, the second quartile, you get more, this is a shared savings rate, so you want to see a positive number. You get a higher shared saving rate, and that is statistically significant. The odd part, the perplexing part, and I'm still to this day perplexed by it because there's no data to help me be unperplexed by it, is if you keep increasing the dose of PCMH, you see that bend down, that the saving rates go down. And in fact, the writers themselves say, the study suggests a U-shaped relationship, and maybe there's an optimal level of PCMH investment for ACOs. Now, before I showed you this, does that square? You would think more is better, of course, right? But the data don't bear that out, which is to ask the question that's twofold. Are we talking about certification? Or are we talking about true clinical change? And is there some PCMH, but not too much? And I don't want to overscope that, but these are questions that need to be asked, right, as part of 5 comprehensive pieces of primary care. Above and beyond the question, are we talking about activities? Are we talking about supply, et cetera? So I think frameworks, what can that help us do? It can provide guidance on what we mean when we say primary care. I think it helps us identify which components need more work, need data, which components have data, et cetera, and how do we organize the data behind it as we say we need more focus on primary care. And in the group that Jeff mentioned at Vessel, we are taking this on in a series of white papers and issue briefs to do this. We're hoping this is a complement. There's good work happening at the state and at the national level and nonprofits doing this. My hope is that together we'll come to a place where when CPC Plus, those results come out, and I do not have a prior about what we're going to see there, and as we see results from all these other primary care models, that we'll be able to say, you know, based on how we've organized these frameworks, that's why these things worked, or that is why it was unlikely to work, et cetera. So that's the vision. So summarizing this section, and before I wrap here, I'll say that, you know, for the reforms of promising evidence, such as ACOs and bundle payments, I think co-participation and overlap, you will increasingly see it. It's already at our doorstep in many ways. And for those with more neutral results, I think frameworks to help us understand why we're not seeing the benefit is really critical. Let me end where we began, where I had some mic difficulties, so thank you for putting up with me on that. We set out to define value in healthcare, and I hope we've done that, as broadly speaking, quality over costs. We define value-based payment reform as shifting away from volume towards value-based incentives within a spectrum, a bigger spectrum of healthcare payment. We define features of 3 prominent programs, ACOs, bundle payments, and primary care models. Talked a little bit about where the evidence is, that on net here we see some positive results for ACOs and bundles. The jury's still out on primary care. And we've talked about a few key emerging topics, co-participation, overlap, and potentially the need for frameworks in primary care. And with that, I'll end, and I'm happy to take questions if we have time. Thank you for your attention.
Thank you, Dr. Liao. I think you're going to have lots of questions here.
Thanks, Josh. That was fantastic. I was wondering if you would comment on value-based models and disparities and equity. You mentioned the hospital readmissions reduction program as well as flaws with that program. You know, there's a literature base suggesting that stratifying these analyses, that it may penalize systems that serve socially complex or disadvantaged patients. Obviously, that could potentially be barriers to entry for such health systems into value-based models, could impact selection, things like that. I can imagine it would differ whether you're in a Medicare program, an employer-sponsored program, mixed payer program, so would welcome comments on that, especially as UW's mission obviously encompasses Harborview in that population.
It's a great question. Thanks, Anders. So I think for those of you who may be on Zoom, the question really was around the issue of disparities in equity in value-based payment reform, and could these reforms, I intuit, worsen or create an unfair, an uneven playing field? If it was already uneven, even worsen it for these things. And I think the short answer is yes, and there are data to support it. I won't belabor that. I have a we could spend another hour or two talking about the data and disparities around value-based payment, but suffice it to say, what I did not show you in the value equation is equity, right? That if you believe a part of high value as a societal thing is to give parity in care, that's not baked into the actuarial calculations, it's not baked into the models, and I would say in the consciousness of most people who think about it, it's not there. I'd like to think that there's a change in that. Very practically, we have an R1 that's working on this issue. There are others around the country who are trying to do this. I would say people out in Medicaid plans, people who work in Baltimore are trying to design models to avoid that issue. Every policy, well, the best thing I could say is every policy in my mind has the intended effects and the unintended effects. The notion that you could ever get to a place where there's unintended effects is, I think, unrealistic. You know, it kind of baked into this idea of values that if we go all the way to the right side of the spectrum, it's good, right? But in fact, not necessarily. If you think about a system in which we get paid per person and you're on the hook for the excess spending, there's skimping in care. There is potential selection, as you pointed out. I don't think there's a world in which we have a system where that's totally solved, but I think it can be mitigated. And I think it highlights the need to put equity in the numerator of the equation, co-equal with the other things, and for more evidence to kind of elucidate that. And that's certainly ongoing now.
Can I sneak by you? Excuse me.
Josh, thanks for a superb talk. It's a lot of information. And I just want to follow up on Anders' comment. This is a bit off target, but I'd like your sort of larger perspective on this. One of our faculty members last night, who's just retiring as director of the Kaiser Permanente Northwest Research Institute, who was a medical director in this hospital at UWMC for 13 years, talked about the fact that the costs of care overall are so far out of control that a third of our population probably can't afford or is underinsured and can't get access, which probably accounts for a large degree of the fact that mortality in this country is declining, maternal mortality, overall life expectancy. And so, where we've got, and this is not happening in any of the other OECD countries, which spend half of what we do. So the question is to put this all in perspective where, these differences, these DIDs are really very small in the overall, and they may marginally affect a hospital bottom line, but probably don't affect in the larger sphere what we're spending on healthcare as a nation and who's getting it is what I think Anders was alluding to. I mean, do you see this sort of, I agree with you, everyone's talking about value and that's the way it's, looks like it's headed, this definition of value which you presented. Does this make any sense in the larger perspective of what we want to do with our healthcare system?
Thanks for that very easy question, Steve. I'll solve it right now. Wow, what a question. So a couple of things here. Let me actually step way back and contextualize what I presented here today and say this is around value-based reform, which has been focused on delivery, right? So when hospitals and clinics and clinicians touch patients, operate on them, manage their conditions, there's a whole world of healthcare out there that perhaps was included in the talk last night about healthcare that's not in this. So, for example, most of us, I think, in medicine know pharmaceutical costs are high. I think the easy focus would be pharmaceutical companies, but there's a whole industry of pharmaceutical benefit managers, right, that would be considered in that drives costs up. Some of you may know this, but there's an emerging segment called lab benefit managers that drives costs. Surprise, there's a radiology benefit managers. And there are these kind of middle layer stakeholders that are not in these reforms that I think drive healthcare spending. When you look at a national perspective, the two things that stick up over the tree line are hospital care and pharmaceuticals. And none of these models include pharmaceuticals. So I do think what this could do in terms of the market shifts, the rearranging of providers, it could, with other policies that are being currently considered, address hospital spending. But I think what is totally out there and outside of this quality focus this value focus that I've given is this issue of pharmaceuticals. We actually have been keeping a close eye on a hepatitis C episode. It's a chronic episode that New York implemented with Medicare, the idea to kind of, high costs. But what they did was they carved out the medication cost because it was too high, right? And all these value-based contracts carved the medications out. So I think short of pharmaceutical reform, I do worry about that. And there are a lot of middle layer stakeholders, and this certainly doesn't touch on that. So I think for what it touches on, I'm hopeful, but that's guarded because of all those things that don't fit under the umbrella of reform.
Do one of you have a question? Oh, okay. One last question do you mind if so Paul first. Get a resident voice here.
Thanks for the great talk. I was just wondering if you could comment on how these models are playing into the University of Washington health system, if at all.
It's a great question. So the question being, how are these models playing into the University of Washington? So as I kind of alluded to, we have a huge, large ACO arrangements with big providers in the state, the Healthcare Authority, and specifically PEB, the Public Employees Benefits Board, as well as Boeing as a large regional employer. And what that does, I didn't show you the slide, but what it does, it kind of takes the middle person of insurer out of it, and it says it's a direct-to-employer arrangement. The idea being that Boeing employs enough people to say, I don't need an insurance company to disperse the risk. I have enough people to absorb that risk, actuarially speaking. And so we have two big arrangements there. One of our hospitals, Valley Medical Center, is involved actually in MSSP, as well as bundle payments, the successor program to the bundle payments program. So we do have pockets of that.
We're always looking at different calls or opportunities when regional payers put out and say, hey, we're doing a bundle. We always try to understand and assess those opportunities. So I think the short way of saying is we're in those, and we're always looking for those that make sense for us. And of course, the things that we don't have a choice in, we're also in. So if our medical directors of the medical center in Harborview were here, they would say, you know, we are subject to these readmission reduction programs, right? And again, they're very close cousins to these programs, but there's a whole range of those that live right next to these reforms that we're in by requirement that we engage in. So.
All right, let's give Dr. Liao one last round of applause.